Hi, everybody. I'm Ashwin.
I'm Raj.
And I'm Eddie.
And this is Blood Cancer Talks. This is a podcast exclusively dedicated to hematologic malignancies, where we bring content experts who live and breathe a particular disease and focus on the latest advances in biology and clinical management. Today, we are excited to talk about the management of chronic phase CML. We have an expert, Dr. Hagop Kantarjian, a professor and chair of the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston. He's also Samsung Distinguished Leukemia Chair in Cancer Medicine. Dr. Kantarjian, thank you so much for joining us and thank you for your time. Before we start, can you tell us about yourself, your clinical and research focus for our listeners?
Thank you for inviting me. So I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson. I joined the leukemia faculty in 1981, and I've had only one job for my whole career. And I do clinical translational research, so essentially taking potential discoveries from the laboratory and moving them into clinical research with the appropriate translational work.
Fantastic. Thank you for that introduction, Dr. Kantarjian. With that, let us jump right in. We'll start with the case, and you can walk us through how you would approach this patient, and we can discuss the data as we go. So I'll start with the case. It's a 25-year-old male with no significant past medical history. Presence after his primary care physician found an incidental on a routine blood count check and was found to have a white count of 54,000. The patient is completely asymptomatic and he's been leading a healthy lifestyle and is referred to you for further workup. In your clinic, he was found to have a white blood cell count of 61.6 thousand with a differential showing eosinophilia and basophilia. Hemoglobin is 13.9, hematocrit is 42, and platelets are 316,000. As I mentioned, he's completely asymptomatic. To evaluate this elevated leukocytosis, patient underwent a bone marrow aspiration and biopsy, which showed markedly hypercellular marrow, approximately 100% cellularity, with predominant myeloid tri-lineage hematopoiesis and megakaryocytic atypia. There is no increase in blast by morphology, immunohistochemistry, or flow cytometry. Karyotype was done, which showed 46XY with classical Philadelphia chromosome translocation 922 in all the 20 metaphases that was done by karyotyping. He underwent imaging as well, which showed enlargement of spleen. So Dr. Kantarjian, in a patient like this, how would you approach, and can you please walk us through your thought process as well as any other diagnostic tests you would like to order?
So today, this is a typical presentation of a patient with Philadelphia positive chronic myeloid leukemia in the chronic phase. Close to 60% of the patients are diagnosed accidentally on a routine physical exam or blood test because in the United States and in many advanced nations, we do routine monitoring with physical exams and blood tests. If you take some of the emerging nations, then many of the patients present with symptoms, and that's because there's a delay in the diagnosis. And usually they present with a big spleen, very high white cell count, and that translates into early satiety, weight loss, abdominal pains. And then there are the more uncommon manifestations in patients still in the chronic phase. So they could present with bleeding events, retinal hemorrhages, with clogging of the vessels, so priapism, cerebrovascular accidents, transient ischemic attacks. But in general, the presentation of CML is the way as this patient has presented. The differential diagnosis will include other myeloproliferative disorders. Usually people talk about a leukemioid reaction, but usually with steroids, with sepsis, the white cell count does not go as high as over 50,000. So when you see any elevated white cell count in a patient who is asymptomatic, you have to suspect CML. But as I mentioned, there are other myeloproliferative disorders, Philadelphia negative CML, myelodysplastic syndrome in proliferation, chronic myelomonocytic leukemia. So of course, the next step is to confirm the pathophysiologic hallmark of CML, and you can do it with a bone marrow with cytogenetic studies that will show the translocation 922, and you can document it either by routine cytogenetics or by FISH. And you have to do pre-treatment PCR, looking for the BCR-able transcripts. And that's important because about 2% of patients with CML have unusual transcripts, the E14A3 and E13A3 instead of the A2. And those are not detected by the routine PCR probes. So this will give a false negative PCR test. And if you don't do it at diagnosis, confirming the FISH to be positive and the PCR to be negative, and you do it only during treatment, you can be under the impression that this patient is already in a complete molecular response when they may not be.
Yeah, that's a very fantastic point, Dr. Kantarjian. One question I had is, do all patients with CML need a bone marrow aspiration biopsy? If so, what is the rationale behind it?
So in the community practice, many of the oncologists have shifted from doing the bone marrow because it's painful, and they do just a peripheral blood for either FISH for the Philadelphia or for PCR. I always advocate to do a bone marrow, and this is in the NCCN guidelines, and we have a lot of discussions about it. But we find that about 10% of patients with CML can have a bone marrow that changes a little bit their prognosis. So the blast in the bone marrow can be higher than in the blood or vice versa. And the same applies to the basophils. You also want to do a cytogenetic analysis, not only to document the Philadelphia abnormality, but also to document the possibility of additional chromosomal abnormalities, which may be important. And then you have to do, in the modern time, a mutational profile, because now we find that about 1 in 5 patients with CML have mutations that we see in MDS and in AML. And the most common is ASXL1, but we see also EZH2, TET2, IDH1, and 2 mutations, DNMT3A, and so forth. Now, we don't know exactly the significance of those mutations, but we know that ASXL1 is associated with cytopenias. And this opens an interesting question. Are these mutations inside the CML clone, or are they independent and more suggestive of an independent myelodysplastic syndrome process? Because when you give tyrosine kinase inhibitors to patients with ASXL1 mutations, they often have recurrent, repeated cytopenias to the point where you cannot deliver the TKI, and they have a much lower molecular response rate. And many of those patients, we have to take them to transplant. Now, as far as their survival, the data is split or controversial. In our experience at MD Anderson, we found that ASXL1 is associated with difficulties to deliver the TKI and recurrent cytopenias, and the need to send those patients to transplant quite often. So their survival is usually acceptable if you treat them optimally, that is, giving them the TKI, assessing their response, and then considering the possibility of a transplant.
And yeah, so the extra molecular aberrations are obviously can be very tricky when they come up. When you look at the additional chromosomal abnormalities, how does that impact the prognosis and treatment decision-making in CML?
Yeah, so let me make one more point, which I forgot, because the question has, do you need a biopsy? I think you really don't need a biopsy in the bone marrow. Some people advocate to do the biopsy to look at the degree of fibrosis, but we have seen that even though patients with CML have some fibrosis, it resolves with TKI therapy. So in my book, a biopsy may not be necessary. Now let's come to the point of the additional chromosomal abnormalities. So we do see in about 10% to 15% of patients with CML additional chromosomal abnormalities. The most common historically used to be trisomy 8, double Philadelphia, and isochromosome 17. And these were features of what we call clonal evolution or accelerated phase disease. Later on, people added some additional chromosomal abnormalities like plus 19, plus 20, and so on. But in general, if you look at the chromosomal abnormalities, the ones that matter are a chromosome 17 abnormality, isochromosome 17, and the very uncommon translocation 3q26, which is the MECOM rearrangement. These patients, when they have the MECOM abnormality, they do not respond to the TKIs. Their median survival is 1 year, so as bad as a blast crisis, and you must take them to an allogeneic stem cell transplant. So the additional chromosomal abnormalities can make the outcome a little bit more adverse. We've seen also chromosomal abnormalities in patients who achieve a complete cytogenetic response. So for example, a trisomy 8 in a Philadelphia negative metaphase or -5, -7. So the trisomy 8 is neither here nor there, but if you find loss in chromosome 5 or 7, you worry that this patient may develop an MDS-like picture, which may be part of the course of the bone marrow of that patient, which has predisposed the patient to CML and could predispose them to MDS or occasionally myeloproliferative neoplasms and so on.
You briefly touched on this already, but just for our listeners, can you explain the clinical differences between chronic phase, accelerated phase, and blast phase CML?
So let's start with the simple one. So chronic phase is the most common presentation. Blastic phase is when the patients present with more than 30% blast in the bone marrow or the blood, and that's by the MD Anderson definition and some others. If you look at the WHO classification, they use the 20% blast cutoff to make it harmonious with the acute myeloid leukemia and the ALL. But we find that patients who have 20 to 29% blast, their survival is quite better than blastic phase. So the median survival in blastic phase is about 1 year if it's a myeloid blastic phase. It's about 3 years if it's a lymphoid blastic phase. In patients who present with 20 to 29% blast, their median survival is about 50% longer. So that's why we like to distinguish this. Now, the definition of accelerated phase started initially empirically through the WHO, and they defined it by increasing blasts or basophils or eosinophils or high platelet count or low platelet count, or a spleen that does not shrink with hydria. In 1988, I did an analysis that defined the 5 criteria for accelerated phase, and these were increased blasts 15% or more, increased basophils 20% or more, low platelets less than 100,000 unrelated to therapy, and chromosomal abnormalities. And that stood the test of time for a while, and actually it is still used today. Now, because the TKIs were introduced and they started improving the outcome of the de novo accelerated phase, the WHO decided to do away with the definition of accelerated phase and to call the old accelerated phase as high-risk CML, so similar to the high SOCA risk. But we did two kinds of analysis. The first one is we looked at patients in accelerated phase by the MD Anderson criteria before 2000 and after 2000. So after the introduction of TKI. And we found that if the accelerated phase is de novo at presentation, we did improve the median survival from 36 months to about 70 months, and with a 5-year survival rate of about 60 to 70%. But that 5-year survival rate is still worse than the high-risk SOCA. So it is still a unique entity where you need to do something different. Now, if you take patients who present in the chronic phase and who have evolved into accelerated phase criteria by the MD Anderson criteria, actually, in the era of TKI therapy, their median survival is still 3 years. So the de novo accelerated phase has a worse outcome than the high-risk SOCAL, and the evolved accelerated phase from a chronic phase has a much worse outcome. So I believe that we have to retain those definitions of accelerated phase because we have to take them into trials of, for example, the new third generation BCR-able TKIs. We have to consider combination therapies in such patients, and we have to consider monitoring them frequently and moving them to transplant, particularly in the patients who present in the chronic phase and then evolve into an accelerated phase.
Yes, so we'll talk about risk stratification. So Dr. Kantarjian, for patients who present with CML in chronic phase, there are several risk scores which are available, like SOCAL score, Hasworth score, which were mostly developed before the era of TKIs. The question is, do you still use them in the era of TKIs to help risk stratify their patients, and what is their role currently in clinical practice?
So I think they still have a role, and there are different classifications, and people get confused. But essentially, most of these classifications rely on an enlarged spleen size, increased basophils, increased blast, and perhaps clonal evolution. And then you classify the patients into low, intermediate, and high risk. I think the most important is the high risk. In the United States, the incidence of patients who present with high-risk CML, it's less than 10%. But if you look in emerging nations, because of the lack of frequent monitoring, many of the patients present with bulky CML disease, big spleens, and they tend to be in the high-risk category. So a very high white cell count, over 100,000, massive splenomegaly, increased blast and basophils. Why is that important? It's important because even though we believe that survival on average in CML is the same with imatinib, the first generation TKI, versus the second generation TKI. It is possible that in the high-risk SOCALs, the patients may do better with a second generation TKI, and perhaps also with a third generation TKI like Asciminib or olverembatinib in the future, or some of those. So and you don't have to memorize the high-risk SOCAL or the high-risk Hasworth or the high-risk UTOS. I think if you have a patient who presents with a lot of symptoms, a massive spleen, a white cell count which is very high, where there's a spillover of the blasts over 5%, basophils over 4 to 8%, these are patients who have high-risk CML.
Thanks, Dr. Kantarjian. As of today, FDA has approved 5 different tyrosine kinase inhibitors for frontline therapy for CML. And the first, as you mentioned, was imatinib, the first generation, followed by the second generation, which includes dasatinib, nilotinib, and bosutinib. And most recently, the controversial approval of Asciminib in the frontline therapy, which we'll talk more in detail. Before we talk about the specific TKIs, what is the aim of therapy for CML patients in the front line?
So when we started in 2000, we had one aim: prolonged survival. And we were happily shocked that not only survival was prolonged, but it became close to that of a normal population. So if you look at the relative survival, matching the patients by age with the normal population, you find that those patients have a relative survival which is similar to an average population. So that was amazing. And then we became a bit perhaps more optimistic. We said, not only do we want to make the lifespan normal, but we also want to be able to stop therapy. So essentially a molecular cure, or what people refer to as a treatment-free remission. And that became a very important aim, particularly in the younger patients, because you don't want to give a 50-year-old person TKI therapy for the next 30 to 40 years, because there could be cumulative toxicities and bad quality of life. So the second aim of therapy became achievement of treatment-free remission. The third aim of therapy became to reduce the side effects. So remember, in the old days, we had chemotherapy drugs, and we developed the drugs at one dose below the MTD. So we did phase 1 studies, and we defined the maximum tolerated dose as a dose that causes grade 3 toxicity in 2 out of 6 patients. So we went one dose below, and we assumed that with this treatment, we could have grade 3 toxicities in 20% of the patients. Now, this was with chemotherapy, which was limited for 3 to 12 months. As we started using the targeted therapies and the TKIs, we realized that in many of them, we have to use them for many years. So we started unraveling toxicities in the long run that could not be defined by the MTD. So more recently, we started talking about an optimal biologic dose, which would be a dose much less than the maximum tolerated dose, which would maintain the same efficacy but reduce the toxicity significantly. And so far, we have defined the optimal biologic dose by clinical experience, but in the new studies, the FDA has required dose optimization, so it requires the investigators to look at 2 different dose levels and to go into the phase 2, keeping in mind that we want to define an optimal biologic dose. So the purpose of this is to reduce the long-term toxicities that we could not define with the early course of the treatment, be it with TKIs or with chemotherapy or with others. And the final objective is to make those drugs affordable and available and accessible to 100% of the patients. So that's why we have to start looking at the price of a drug, a TKI, in a year compared to other TKIs which exist, and defining a treatment value. So the 4 aims of therapy are survival prolongation, achievement of a molecular cure or a treatment-free remission, minimizing the short and long-term side effects, and then finding a drug that's available and accessible to all the patients rather than to the privileged few. Now, let me talk about treatment-free remission, because you hear people say that with our current therapies, the TFR rate would be about 20 to 30%. So if you take 100 patients, you can get a deep molecular response in about 60, and then you stop the therapy after 2 years, and 30 will relapse, and the other 30 will maintain a TFR. So the TFR rate is usually reported to be 30%. But I think with the current tools, the TFR rate can be much higher, because if you continue therapy, be it with either imatinib or second-generation TKI for long enough, you can get a deep molecular response, so BCR-ABL transcripts less than 0.01%, so MR4, you can achieve that level in 80% of the patients. If you continue the treatment for 5 years in a deep molecular response and you stop, then the relapse rate is only 15%. So 80% of the patients, 80 to 85, will remain in TFR. So if you multiply 80 by 80, actually the today's TFR rate under optimal conditions could be twice what is reported, so about 60%.
Fantastic, Kantarjian. So you briefly mentioned about the efficacy of one agent over other. Is there any instance you would choose a second generation of TKI over the first generation of TKI, which is imatinib?
So let's talk about survival as the aim of therapy. If you look at survival as the aim of therapy, actually on average, imatinib and the second generation TKIs, all they normalize survival. So if you're looking at survival as the endpoint, then a generic imatinib, which through cost plus will be about $400 to $500 a year, would be your best choice. And also we have the longest follow-up with imatinib, and we know that in general it is the safest drug. Why do I say it's the safest drug? Because I want to compare it later with the Asciminib experience. If you look at the German trials, which have used imatinib-based therapies, and you look at the 10-year follow-up, the rate of changing from imatinib to other TKI over 10 years is 25%. 10% is for resistance and 15% for side effects. So the actual resistant rate with imatinib is 1% per year. The actual toxicity rate that forces you to change therapy is 1.5% per year. These are very low rates compared to what is now reported in the randomized trials. And I think it's because somehow there's a bias against the control arms where the investigators do not like to keep the patients on a standard of care, be it imatinib or perhaps bosutinib in a second-line therapy. So what you see is a high rate of treatment interruptions and discontinuations in the control arm, which we have not seen in the previous studies where imatinib or the second-generation TKIs were the investigational arm. So I think there is an element of bias or lack of equipoise where we are treating patients in the control arm in a more adverse fashion than in the patients in the investigational arm. Now, if you look at treatment-free remission, the second-generation TKIs can achieve a major molecular response and a deep molecular response a little bit faster than the second-generation TKI and significantly faster than imatinib. So if the aim is a treatment-free remission, particularly in a young person or in a woman who wants to become pregnant, then I think the second-generation TKIs would be appropriate. Also, I would use the second-generation TKIs in patients who have a high-risk SOCAL. Now, let's talk about the second-generation TKIs. Of the 3 second-generation TKIs, dasatinib, bosutinib, and nilotinib, initially, nilotinib was the one that's most commonly used. But with the 10-year follow-up, we found that nilotinib at 300 milligrams twice daily was associated with an incidence of arterio-occlusive events, which was 25%. So we shifted back to maybe using dasatinib. And at MD Anderson, we found that dasatinib 50 milligrams a day was as effective and much safer than the 100 milligrams a day, which is the FDA-approved dose. And remember, dasatinib has become generic in the United States as of last month. Now, the price of it is still high because there's only one generic. But I'm hoping that by next year, if Cost Plus or the other companies get into that market, then the price of dasatinib will be less than $1,000 a year. So then you have to compare it with other TKIs where the price is over $100,000 a year. So if TFR is the endpoint, then I personally favor dasatinib 50 milligrams daily. Bosutinib is a good drug also. If you use bosutinib, you have to do a dose escalation, because if you start with the bosutinib 400 milligrams a day, many of the patients will discontinue therapy because of the early GI toxicity, which is self-limited. So I usually start with bosutinib 100 to 200 milligrams a day for 1 to 2 weeks, then 300 a day for, and then go to the full dose. And that avoids the discontinuation rate from the early GI toxicities, which was the problem in the randomized study in third line of Asciminib versus bosutinib, where it was used at an initial fixed dose of 500 milligrams a day, which led to a high discontinuation rate in the bosutinib arm.
You already mentioned about the second generation TKIs, but in all the clinical trials with second and third generation TKIs in frontline therapy, even though they had significant deeper and faster responses, still there was no impact on overall survival. Why is that?
I think it's very simple. We assumed as investigators that the early surrogate endpoints will translate into a better survival. And that turned out to be true only for a complete cytogenetic response. So a PCR of less than 1% by 1 year or later will translate into a normal survival. If the PCR is over 1%, particularly if it's over 10%, then the survival is shortened. And the second thing is we have very effective salvage therapies if we identify the resistance early on and change the TKI. So the reason why the survival has not changed with imatinib versus second and perhaps third generation TKIs is because the survival is near normal already, even with imatinib, and because we have effective salvage therapy. So even though we can get to a major molecular response and a deep molecular response earlier, those molecular responses can happen later and they translate into a normal survival. So I like to use the proverb, all the roads lead to Rome. So you can get to an MMR or a DMR, whether you take the longer route via imatinib or the shorter route via a second generation TKI or perhaps Asciminib.
I like that overall framing of the goals of treatment. It's very handy. Now let's come to Asciminib. What do you make of the significance of Asciminib's mechanism of action in terms of targeting the ABL myristoyl pocket in the treatment of CML?
So at the beginning, all the TKIs that were developed were TKIs that targeted the ABL kinase domain. The development of Asciminib was unique because the investigator said, we don't want this TKI to bind to the ABL kinase domain. We want it to be selectively targeting the ABL myristoyl pocket, which is different from the ABL kinase domain. So in the sense, the mechanistic difference is what excited investigators. And it made us think that perhaps if you have two TKIs that bind at different sites, then by combining them, we can synergistically improve on something. And that something would be the treatment-free remission rate. So far, we have not proven this. And when we combine two TKIs, there is an added toxicity profile that is not anticipated with each of them alone. So there could be an added synergistic toxicity. That's why I have not advocated for combining two TKIs, even though some CML experts have advocated for that. So the fact that Asciminib and some of the newer STAMP inhibitors target the myristoyl site is an added benefit because we have now new TKIs that could work in situations where we have mutations in the ABL kinase domain. Now, having said this, we're starting to see mutations in the myristoyl site emerging with Asciminib therapy. And I'm a bit concerned that the incidence of those mutations may be a bit higher than we anticipate. And maybe we do see mutations without this translating into true clinical resistance. So now we have to rethink the process of if we identify a mutation in a patient who's responding, does it really mean resistance or is it simply a relative resistance? So this is what we see, for example, with the menin inhibitors in acute myeloid leukemia. We noticed that on therapy, 40% of the patients develop MEN1 mutations, but some of them are still responding very well. So now we have to redefine whether each and every mutation in CML necessarily means resistance or not.
Yeah, that's very wise advice. I think let's springboard off that and jump into talking about the ASC4FIRST trial. Of course, it was a phase 3 trial, which compares Asciminib versus either imatinib or a second generation TKI, and we'll come back to the control arm in a second, in patients with treatment-naive CML in chronic phase. The primary endpoint was MMR defined as a BCR-ABL less than 0.1% at 48 weeks, and about 200 patients in each arm. And about half of the investigators elected TKI, the control arm, received imatinib, a quarter received nilotinib, 20% dasatinib, and 5% bosutinib. And the MMR rate at 48 weeks was 67% with Asciminib versus 49% with the physician choice TKI. So what do you think the implications are of in the first of the higher MMR rates observed with Asciminib, especially when we compare against patients receiving imatinib?
So let's talk about the endpoint of MMR first. So as you know, historically, we thought that an early molecular response would translate into a better survival. And with the experience, as I mentioned, the only parameter that translates with an improved survival is a complete cytogenetic response, or a PCR less than 1% versus more than 1%. An MMR has translated sometimes into an improved event-free survival, but events have been defined loosely, particularly incorporating factors that do not translate into a survival benefit. Now, the use of MMR at 12 months into the frontline and at 6 months into the salvage therapy has been very useful because it allowed us to get FDA approval for drugs that might not have had an approval that early on if survival was the endpoint. So this was very good for the research and for the patients because we have now 6 TKIs that we can use, 5 of them in the frontline, all of 6 in the salvage, because you could have a patient who fails the second generation TKI for toxicity, and you can give them imatinib. So all the 6 TKIs can be used in the salvage setting. So that was very good. Now let's look at the endpoint of MMR. Has it ever translated into a survival benefit? It has not. Has it ever translated into a higher rate of treatment-free remission? We have not proven that yet. So if you look at the 4 endpoints of therapy, even though Asciminib is FDA approved in the frontline, we have to wait for 3 things to realize, because survival is not going to be better. We have a relative survival at 10 years of 92%. So maybe Asciminib will improve it to 94%, but that's going to be probably statistically not significant. So then does it improve the TFR rate? We have not shown this. Second, does it associate with less toxicities in the long run? We do not know that yet because we don't have an 8 to 10 year follow-up. Remember, with the nilotinib experience, at the 5-year follow-up, there was a publication stating that there were no safety concerns. At the 10-year follow-up, the arterial occlusive events emerged. Now, how about the cost? Because maybe Asciminib will be much cheaper than the others. And unfortunately, that's not the case because Asciminib is priced at about $300,000 a year for a dose of 80 milligrams a day. So really, even though the endpoint of the study, an MMR, was achieved and led to an FDA approval, we still have not found that Asciminib fulfills any of the 4 criteria for frontline therapy to replace the existing TKIs. So I'm personally a bit cautious. I'd like to wait longer to look at the long-term toxicities of Asciminib, to look at the mutation rates, and I would like to see the price of Asciminib come down to a level that gives it a good treatment value.
Yeah, I like those criteria that you lay out. What do you make about the choice of the control arm? Would you have done it the same way again, where you give the investigator choice in the control arm, or would you have made it a cleaner study by picking one agent to represent the control arm?
No, of course, if you want an FDA approval, you choose the weakest control arm, right? But then this does not give you an equipoise. And this is something that the cancer experts have practiced for the last 20 years, and they have accepted this. So if you look at myeloma, for the longest time, the control arm was melphalan. If you look at chronic lymphocytic leukemia, for the longest time, chlorambucil was the control arm. So always the control arm is chosen as an acceptable standard of care, but you want probably the one that gives you the maximum difference in the benefit. So the choice of the control arm, be it imatinib, 50% of the cases, second generation TKI chose, was an outstanding trial to get us an FDA approval, which it did. The question now is it true that Asciminib is better than imatinib for survival, or is it better than second generation TKIs for treatment-free remission? And finally, is it less toxic and does it have a good treatment value? So let's talk toxicity because that's one of the questions that's emphasized in the follow-ups. What they say is the treatment discontinuation rate was the lowest with Asciminib. So when you look at the treatment discontinuation rate, it was 4.5% with Asciminib, 11% with imatinib, and 10%, 9.8% with second-generation TKI. But as I mentioned,
it's an open label study.
Huh?
It's an open label study.
It's an open label study, but also if you look at other studies with imatinib, so if you look at the German trial with imatinib-based therapy, at 10 years, the discontinuation rate was 25%, so 2.5% per year. The follow-up on the Asciminib versus TKI trial was, I think, 1.5 years. So in the imatinib arm, the discontinuation rate should have been about 4%, and it's 11%. Good. So that tells you that there's a bit of a bias in trying, and maybe it's an unconscious bias, prejudiced against the control arm to try to look at the toxicities in a different way and discontinuing TKI therapy on imatinib more so than with second-generation TKIs and more so than Asciminib. Remember, the reality is the second-generation TKIs on average are more toxic with regard to serious toxicities. And yet the discontinuation rate on the study was slightly higher with imatinib than with second-generation TKIs. Now, if you look at even at the MMR endpoint, the study does not specify the comparison to the second-generation TKI. So even though numerically, the incidence of 12 months and 24 months MMR rate might be slightly higher with Asciminib than second-generation TKIs, those curves are trending very close together. So I think in the long run, it's possible that the cumulative incidence of MMR and deep molecular response rate will be as high with the second-generation TKI as it is with Asciminib. But we'll have to wait for a longer-term follow-up to see if that would be the case.
Yeah, so if we build on the discontinuation data that you mentioned and talk about grade 3 or higher adverse events, they were 38% in the Asciminib arm compared with 44% imatinib and 54% in the second-gen TKI arms. What do you make of that endpoint in terms of how it would impact patients' quality of life?
So I think grade 3 toxicities are important, but remember, there are different forms of grade 3 toxicity. So with dasatinib, what we worry mostly about is pleural effusion. And that's why we try to reduce those, as well as myelosuppression, which is not that important. And it's more so with the 100 than with the 50 milligrams. And also we worry about pulmonary hypertension, which is 1 to 2%. If you look at bosutinib, the 3 patterns of toxicities are the early GI toxicity, liver dysfunction, and renal dysfunction. And those are manageable with those adjustments. And with the nilotinib, it's essentially the arterio-occlusive events, which are really the prohibitive element. And you have to look at increase in the blood sugar. So in patients with diabetes and also in patients with pancreatic inflammation, you have to avoid that. So you have to look at the toxicities as completely different from each other, even though what we have found also is some cross-intolerance. So we find now today that patients who have a pleural effusion on dasatinib have a higher tendency to have a pleural effusion on bosutinib. So there are some forms of cross-intolerance. Now, of all the TKIs, I think if you keep Asciminib aside, the safest TKI is imatinib or dasatinib 50 milligrams a day, or maybe the other TKIs at a lower dose schedule. If Asciminib turns to be as safe as the imatinib in an objective analysis rather than in this form of analysis where the investigators may want not to use imatinib, so there's no equipoise in the treatment choice, if Asciminib shows the same safety profile, then it will gain momentum, particularly if the price goes down. But if you look at the last ASH meeting, there's an update from Australia with a median follow-up of 2 years, where they report an incidence of arterio-occlusive events of 12%. So that's something to watch for, because it's possible that we may be underreporting the Asciminib side effects because of the extreme enthusiasm of the CML experts, including myself, to try to get more and more effective drugs in chronic myeloid leukemia.
So, Dr. Kantarjian, this clinical trial led to the FDA approval, accelerated approval. But my question is, do we need accelerated approval in frontline CML when we have so many TKI options?
I think I personally say we do, and that seems to be a bit different from the earlier endpoint. I prefer more drugs to be available to the patients rather than less drugs, because the real research starts when the drug gets an FDA approval. The process of the investigational studies is just to put a foot in the door to get the drug into the hands of investigators and do more investigations with different dose schedules, with effective comparisons, and so on. So to me, the fastest process to get a drug to an FDA approval is the most beneficial way to get the patients to benefit from those treatments. Remember, Ara-C, cytarabine, the cornerstone of AML therapy, was FDA approved in, I think, 1968. Today, 5 decades later, we're still investigating different dose schedules of cytarabine. The same applies for anthracycline, the same applies for imatinib, and so on. So really, if we do not have an FDA approval and the drug in the hands of the investigators and the patients, that would be the biggest loss for research and for patients' benefits. So I definitely want accelerated approvals of the drugs. I want more drugs to be in the hands of the patients and investigators, because I think this is the best way of testing them more effectively and making them more valuable and more beneficial to the patients. So I am in favor of accelerated approval, and I'm happy that Asciminib and many other drugs have had an accelerated approval, allowing us to have them and use them. I'm going to give you an example. For example, the Mylotarg. Remember the Mylotarg, gemtuzumab ozogamicin, the CD33 antibody drug conjugate. It was FDA approved in 2010 based on the salvage studies. Then there was a faulty SWOG trial that used a lower dose of anthracycline in the investigational arm with Mylotarg and compared it to 3+7, and they found that Mylotarg was more toxic and the survival was the same. So the approval was in 2000. The drug was withdrawn from the market in 2010, and then it took the maturation of randomized trials and a meta-analysis to get the drug back into the market in 2017. So we had a period of 7 years where a very effective drug in APL, in core binding factor leukemia, and in the intermediate acute myeloid leukemias, which was not available because of a faulty trial. Now you could say, well, why did the drug company withdraw the drug from the market? The reality is the drug was not selling. The total sales were $20 million. So the company felt it was too expensive to produce the drug, and it was not financially beneficial. And that's why they were so willing to discontinue the drug from the market. And you've seen this now with other drugs which are in the market that suddenly disappear because there's a new version which is patented and much more expensive that replaces the drug. So that happened, for example, with pegylated interferon versus the raw-peg interferon. It has happened with the older formulations of asparaginase versus the newer formulations. So I'm in favor of keeping the drugs in the market and having generic companies produce them so the patients continue to benefit from them.
So, Dr. Kantarjian, bringing that all together, has Asciminib got enough data yet to convince you to use it in the frontline setting?
To sum up the Asciminib, I think the Asciminib is a very important addition to the CML-TKI treatment armamentarium, both in later line and in frontline therapy. It allows the patients access to a new drug that could be effective when the other TKIs are not effective. I believe that we have to continue to monitor the data with Asciminib based on the cautionary statements I mentioned earlier, the incidence of side effects and the incidence of mutations. And I would like Asciminib to fulfill at least one or more of the criteria of the four main aims of therapy: prolonging survival, which is going to be difficult to show, improving the TFR rate, showing truly less early and long-term side effects, and then the pricing to be more of a good treatment value, particularly that we will have two generic drugs, which soon will be priced at lower than $5,000 or $1,000 a year.
So, Dr. Kantarjian, coming back to our case, a young gentleman, what would you recommend as a TKI?
So in this young man, I would recommend either generic imatinib or dasatinib 50 milligrams daily, because dasatinib 50 milligrams daily will be much less toxic. It will be as effective as any of the TKIs, and it will be priced at half of the price of the dasatinib 100 milligrams. So these are the two choices for this particular patient. If it was a patient with high-risk features, then dasatinib will be the preferred drug, again at 50 milligrams daily, in my experience.
And what are the molecular milestones you want this patient to achieve over the next 2 years?
So let's talk about the milestones, because as you know, there are the European Leukemia Net recommendations and then the NCCN guidelines. And those, I believe, are quite complicated. I barely can remember them because they have milestones at 3 months, 6 months, 1 year, 2 years, and later. And then they look at an early hematologic response, complete cytogenetic response, a major molecular response. In the long run, it was found that many of these criteria have not translated into a better long-term outcome. So, for example, in the ELN guidelines, there was an emphasis on achieving BCR-ABL transcripts less than 10% at 3 and 6 months. This was based on a study by Dr. David Marine from England that reported that patients who had BCR-ABL transcripts over 10% at 3 months had a 5-year survival of 50% compared to 90%. Nobody has shown this. And I think the difference is in England in those days, if the patients had a bad outcome early on with imatinib, they were either given Hydrea to save money or they were moved to an allogeneic transplant. All the other studies have not shown that achievement of an early hematologic response, namely BCR-ABL transcripts less than 10% at 3 months, is important. Now, you could argue about early hematologic response at 6 months. It is true that a patient who has transcript over 10% at 6 months on imatinib should be changed to a second-generation TKI. If they have high levels at 6 months on second-generation TKI, I would not change because there's nothing better than those. Now, if you look at the 12 months response, you have a response at 12 months of BCR-ABL transcripts less or over 1%, and that distinguishes failure. Again, we found that that is truly not a failure, and there are many patients who are up to 10% who still do well with a good long-term survival. So really, the cutoff of 1% would have been better if it was at 10%. Now, let's assume 1% is a good cutoff at 1 year or later. That defines quote-unquote resistance and a shorter survival, which is mostly driven by the patients who have transcript over 10% rather than the 1 to 10%. Now, also the guidelines mention that an MMR, lack of achievement of MMR at 2 years or later, could define a failure. So what you see in the practice is many oncologists and patients want to change TKI therapy if their BCR-ABL transcripts are even 0.1% or 0.05%. I think this is a very common practice, which is more harmful than helpful because it discards TKIs which can be effective in the longer run, and it replaces them with TKIs which can have additional new toxicities and which could be expensive. So I never change a TKI for BCR-ABL transcripts less than 1%, unless there is a trend for the levels to continue to be going higher. But there's no harm in waiting until the BCR-ABL transcripts are at 1%. There's no reason to change a patient who does not have an MMR at 2 years or later, because they can still linger on with that level with a normal life for the rest of their lives.
Fantastic. Given we have so many TKIs to offer our patients, is there any role of allogeneic stem cell transplant in chronic phase CML?
A very important question, and I think I'm guilty of the fact that allogeneic transplant is underutilized, because people may remember when imatinib came about, it was called STI-571. And because I was young and provocative, I went in a meeting and I said, STI stands for Stop Transplant Immediately. In fact, it's Select Transplant Intelligently. So I think over time, because the TKIs were so effective, people started not wanting to use the allogeneic transplant. And so today, I think it's underutilized because we have 6 TKIs, and because the patients do very well and they can live their normal life, even without a complete cytogenetic response if they are over the age of 60 to 70 years. So the allogeneic transplant is underutilized. And this is exemplified again by the German experience, where in about 1,500 patients over 10 years, only 9% of the patients required allogeneic transplant, either in the chronic phase for resistance or in the transformation. So a very low access rate to allogeneic transplant. I think allogeneic transplant should be considered in any patient who has true resistance to a second generation TKI, a patient who has accelerated phase features, a patient with a T315I mutation, or a patient who has cross intolerance to multiple TKIs. If you look at transplant, it's a one-time procedure. In the United States, it could cost anywhere from $300,000 to $500,000. Outside the US, it costs as little as $20,000 to $40,000. And it is a one-time, safe, and highly curative procedure. If you look at the hazard ratio or the mortality rate with transplant versus ponatinib, which is the most potent TKI, the hazard risk is used by 90% transplant and only 50% with ponatinib. So aside from the fact that it is the most effective and reasonably safe, it is also a good treatment value, because the cost of a transplant in the United States is as much as 1 year of the most expensive TKIs like ponatinib and Asciminib. And remember, for T315I mutations, Asciminib has to be used at 200 milligrams a day. And the price for that, even with the new 100 milligrams pills, is about $630,000 per year. So a transplant, a one-time procedure, could be more effective than the most potent TKIs, and it is of a much better treatment value. So I think we should start considering doing a transplant in a younger individual under the age of 60, 70, as soon as they have shown true resistance to one second-generation TKI without a guiding mutation to direct the patient to another second-generation TKI. If we want to use the third-generation TKIs, they should be considered with in mind to be a bridge to an allogeneic transplant rather than a 5 or 10-year long-term therapy.
Thank you so much, Dr. Kantarjian. As a final question, as someone who has shaped the field of leukemia research, if you were to advise a young hematologist like ourselves entering the field today, what are the key areas of research or clinical practice you would emphasize as critical for the future?
I think that young people like you are to be envied because you're moving into the field of leukemia with a lot of important discoveries on hand that encourage you to have the potential to cure all leukemias in your lifetime. When I started in 1981, the cure rate in AML and ALL with intensive chemotherapy was about 30%. There were no cures for either CML or CLL. With CML, it was busulfan or Hydrea. With CLL, it was chlorambucil. Today, both the chronic leukemias are functionally and potentially curable with our existing drugs. So in CLL, I believe the combination of a Bruton tyrosine kinase inhibitor with venetoclax is going to be curative if it's given for 2 years or more. CML, we discussed it already. In acute lymphocytic leukemia, we're having tremendous discoveries in both Philadelphia positive ALL and pre-B-ALL with the new tyrosine kinase inhibitors, with the antibodies that target CD19, CD22. So it is a great time because we still have a lot of research to do in AML. We have to refine our knowledge in the chronic leukemias and in ALL. And most importantly, there hasn't much been done yet in either MDS or in the myeloproliferative disorders. So I think you are getting into the field of leukemias where you have, on one side, very highly curable diseases that you can treat and be satisfied with. On the other hand, you have diseases which are challenging that you can make important discoveries to be able to say that you have seen the cure of all leukemias in your professional lifetime. So very positive area of research and treatment with very rewarding findings in the long run.
Thanks a lot, Dr. Kantarjian, for your time. We look forward to having you again on our podcast in the future.
Thank you for inviting me. Take care.
Thank you.